Welcome to today's Explainer. We're putting on our detective hats to solve a real-world medical coding mystery. Look, if you've ever stared at a patient's chart and felt like you were trying to decipher some ancient secret language, well, you're absolutely in the right place. Today, we're going to break down a really specific but super common scenario. We'll decode it step by step, find the true narrative hiding in those clinical notes, and translate the whole shebang perfectly into the correct codes. Let's get into it.
Here is our game plan for today. 1. The patient case file. 2. Analyzing the clinical clues. 3. Consulting the coding guidelines. And 4. Finalizing the correct codes.
Section 1. The patient case file. Let's open up the chart and meet our patient. So, the ultimate question we've got to answer today is exactly how should this specific scenario be reported? You know as well as I do, accuracy is literally everything in our field. Just one wrong code, boom, denied claims, costly audits, or an inaccurate medical history that follows the poor patient around for years. We aren't just looking at medical jargon, right? We're looking at a human being's actual medical journey. So, how should this visit be coded? Let's check out the evidence.
Okay, here are the raw facts straight from the chart. Our patient had breast cancer and underwent a lumpectomy. After that, she had chemotherapy, which was completed exactly 2 years ago. And today, she's presenting for follow-up imaging. Most importantly, the results of that imaging show absolutely no evidence of recurrence. These 4 little bullet points are our raw materials. They're the foundation of this entire coding mystery, so we've got to read them incredibly carefully.
Section 2. Analyzing the clinical clues. Time to look past the surface.
Let's cover some coding basics using a really simple 3-step method to crack this case. Step 1, review the documentation, which, we just did. Step 2, identify current versus historical conditions. Honestly, this is where so many coders get tripped up, blurring the lines between what happened then and what's happening now. And Step 3, always check the guidelines to make sure your logic is totally bulletproof against any audit.
Looking at our patient's timeline, there's a crucial detail staring us in the face. That 2-year gap since treatment ended. It's been a full 24 months since the lumpectomy and the chemo. Today's visit is strictly for follow-up imaging, and thank goodness it shows no recurrence. Building this kind of mental timeline is absolutely crucial for separating the past from the present, so we don't accidentally drag a past diagnosis into today's active problem list.
So, the pivot point of our whole case is figuring out, are we looking at an active, ongoing disease or a personal history of a resolved condition? If we code this as an active breast cancer case, well, we're completely misrepresenting the patient's current health. That kind of mistake messes up their permanent record, it skews clinical data, and it creates massive headaches for insurance processing. We have to be incredibly precise when drawing that line between active treatment and history of.
In medical coding, sometimes what the doctor doesn't write is just as important as what they do, because the documentation clearly states chemo was completed 2 years ago and there is zero documentation supporting ongoing treatment. We know for a fact this is strictly historical. The physician didn't note any current radiation, no oral chemo, no active interventions whatsoever. That silence? It confirms our suspicion. We are 100% dealing with a history code.
Section 3, consulting the coding guidelines. Let's hit the official rulebook. We never just guess, we verify. As coding detectives, we rely heavily on the official ICD-10 CM guidelines, specifically IC21.C.8 for this one. This is our holy grail for this exact scenario. Because listen, it's not enough to just memorize codes, right? You have to know the rules that govern how and when they're actually applied together so you don't get rejected. Let's see what the rulebook dictates here. This specific guideline explicitly tells us to assign Z08 when the patient is no longer being treated for the condition or for any sequela. And our patient, she's definitely not being treated for breast cancer anymore, plus she has no sequela, which, is really just a fancy medical term for lingering late effects or complications from healing. She's simply here for routine follow-up.
Okay, before we put all these clues together to officially solve today's case, please do me a quick favor. Make sure to like the video and subscribe to my YouTube channel for daily updates and coding tips. If you're really trying to master the art of medical coding, hitting that subscribe button ensures you'll get these explainers delivered straight to you every single day. Section 4, finalizing the correct codes. The clues are analyzed, the rules are checked. Let's reveal the solution. First up, we've got 08. This perfectly matches our scenario of a patient who has completely finished treatment and is just here for follow-up imaging. This code is great because it tells the story of exactly why the patient is in the building today. They aren't here because they're actively sick. They're here for surveillance. Surveillance is the magic word here.
Next, we have Z85-3. This code accurately captures the historical condition, a malignant neoplasm of the breast with no current recurrence. While Z08 tells us why they're here, Z85-3 gives us that crucial context of what we're actually surveilling. It tells a really triumphant story, right? She fought breast cancer in the past, and she is completely clear today.
When we map our clinical clues straight to our final codes, it's like a puzzle snapping together. The follow-up imaging with no ongoing treatment, that points directly to Z08. The history of breast cancer and completing treatment 2 years ago, that points straight to Z85.3. Breaking it down like this removes all the ambiguity. We've matched the evidence to the correct codes flawlessly. Bringing it all together, reporting both Z85.3 and Z08 accurately tells the complete medical story of today's encounter. Honestly, you need both to paint the full picture for the insurance company and for the patient's long-term record. Based on the guidelines we just reviewed, these are definitely the codes to assign. Case closed.
As we wrap up this explainer, I want you to look at your own charts tomorrow and ask yourself a question. What other conditions in your clinical notes are secretly hiding a history of code? Are you accidentally coding active diseases and risking a massive audit just because you didn't check the timeline? Keep our 3-step method in mind. Always verify your timelines and keep consulting those guidelines. Until next time, keep investigating and happy coding.